The present case report describes a pediatric patient who presented with Flexor digitorum profundus FDP entrapment after a forearm fractures. The patient was diagnosed with a Bado type 1 Monteggia fracture. The fracture was treated with closed reduction and a fluoroscopy followed by Kirschner's wire fixation. This case is unique because the FDP was found entrapped in the fracture site 2 weeks post-operation and was managed using the conservative therapy. FDP entrapment is typically managed by the surgical intervention, and there have been no previous reports of the conservative management. The FDP was released using the passive extension of the index finger under general anesthesia, and no irreversible damage to the tendon or muscle was found. This case report demonstrates the potential for the conservative therapy in the management of the FDP entrapment after forearm fractures.
The patient we described in this case report was a 6-year-old female who had suffered a Bado type 1 Monteggia fracture after a fall. To treat the initial fracture, closed reduction and K-wire fixation were performed immediately, and no symptoms of entrapment were observed. No neurological deficits or vascular issues were seen, and the patient was discharged. At the 2 weeks post-operation checkup, the FDP entrapment was diagnosed using physical exam, clinical findings, and imaging. 3 treatment options were planned, with joint mobilization as our first choice. If this was unsuccessful, open FDP release was the first backup. If the problem remained unresolved with both therapies, reproduction of the original fracture to release the entrapped FDP was planned. This was the process for joint mobilization seen in this perioperative video here. Passive joint mobilization using a delicate technique was necessary to prevent damage to the muscles or tendons. Under general anesthesia, with the right index finger gradually extended using passive motion, the PIP and DIP joints were extended to 0 degrees. FDP release was confirmed using physical examination of the finger. The post-operative rehabilitation plan employed was active motion, passive motion, swelling and pain management, along with place and hold regimens in order to aid in the restoration of range of motion and strength. Although weakness of the joint was observed immediately after the release of the tendon, after rehabilitation, the function was restored back to normal.
A conservative approach may be worth considering as a primary treatment method, owing to its ability to promote recovery through rehabilitation. Evaluating the dynamic tenderness effect and checking for pain or stiffness during wrist extension are critical for early intervention. It is important to prepare for open release of the FDP when there is suspected muscle or tendon damage to prevent further complications.